The ICU is a place where a hospital spends about 40 cents of every dollar in their ICU. It has traditionally been understaffed and undermanaged, particularly on the physician side. 4 out of 5 ICUs don't have any ICU specialist in them at all. That creates a problem in our ICUs where there are a lot of errors. There are actually several studies that show 55,000 people a year die in our ICUs, preventable deaths.
If I was to go into a room in an ICU where you operate, what would I see? What would it look like?
So in the patient's room is a camera, which is very sophisticated now, and we can see the patient's pupil, we can look at their skin, we can read their IV bags, their ventilators. There's a monitor, just like what sits on your desk for your computer, so that when we're conversing with the family, they can see our face, they know who we are, and the camera we control, so we can look around the room, we can look at all their devices, we can look at the patient. And then the only other thing in the room is an emergency button, so that if a clinician walks into the room and sees the patient's in distress, they can push that button and they immediately have our physician with that monitor coming into the room and starting a conversation with them. So if you do Skype, it's sort of like Skype on steroids from that point of view.
And then from the other point of view, from your team of physicians
Right.
in St. Louis, what are they looking at and what are they looking for?
So the other piece of the technology is that most hospitals, many hospitals today, have an electronic medical record. All of you have seen the TV shows, those boxes with the wiggly lines, which is heart rate and pulse, those sorts of things. The lab and the pharmacy, we write interfaces from whatever that hospital has into our monitoring center. So then our physicians and our nurses, some people say it's like air traffic control. They have a number of screens, and the technology is saying to our clinicians, these patients over here, we set a plan of care, they're on track, they're fine. These patients look a little wiggly, and these people are falling off the trail. We need to intervene immediately. So it leverages the labor in such a way that it's very much more spreads the expertise over a much greater number of patients.
There must be a conversation that happens when a family member is entered in the ICU and you explain to them, well, your doctor is going to be on this computer screen. He's actually in St. Louis. Do patients like that? Are they nervous about that?
So generally speaking, the patients think it's kind of cool. So, it's like it's technology, and our staff, we train them to be really friendly, and so when our nurse comes on, they're like, hi, how you doing, and talk to the family members, and is there anything you need, any explanations, that sort of thing. So generally speaking, the families really embrace this. And part of it is we educate the family. We're not here to supplant their physician. We're here to collaborate and back up their physician and the nurses, because they all know the nurse can't be in the room with them all around, 24 hours a day at their bedside. So this extra set of eyes and ears, we explain it that way, is there kind of keeping an eye on you, generally speaking, so that if something changes, somebody's right there who can respond.
If something goes wrong, is the hospital still fully liable? Is the attending physician on your end liable? How does that work?
So our physicians have to be licensed in every state in which we practice, and we're credentialed at the hospitals in every state, in every hospital in which we practice. That enables us to actually give orders to the nurses and tell them what to do. So if I or one of my doctors gives an order for the wrong medication or the wrong dose of a medication, then we're going to be responsible for that. And so our med mal is just like any other physician's med mal on the medical staff. But if we think about what creates medical malpractice situations, by and large, 2 big things: bad outcomes and bad communication. So we have a big improvement here, right? So communication, way better than what it was before. The other thing that causes, of course, bad outcomes. So with our system installed, we have seen a 40% improvement in mortality year over year. So you have a lot less bad outcomes. So you have your risk goes down dramatically.